This is Occupant Factors and Injury Patterns, and I am Carla Kohida-Ingalls, Program Director for the International Center for Automotive Medicine. The purpose of this module is to teach you how to recognize how to use occupant factors to determine which patients may need special consideration, and an understanding of how the injury patterns are tied to occupant factors. We have a special emphasis on pediatric, elderly, and obese populations. The take-home lessons for this module are that occupant body composition affects injuries, same characteristics affect recovery and outcome, and it's the occupant, it's the occupant, it's the occupant. I'm going to take you through a crash where there were two occupants in a vehicle. The restrained driver fell asleep and lost control of his vehicle, which was a 2005 Chevrolet SSR. He drove through a median until he came to an overpass, vaulted 25 feet to a roadway under the expressway. He struck the roadway just prior to striking the median wall and was then struck by another vehicle, which caused him to rotate and strike the median wall a second time. This is the approach. The vehicle was heading down the roadway and he went off the highway to the left. He entered the grassy median, continued through the median until he came to this roadway under the highway, where he drove off the edge of the median, bounced down this grassy section over the next wall and into the roadway. Here the vehicle had an impact with the road surface first and then the opposite concrete barrier. And this is just a close-up of the concrete barrier where he struck it. The front-end damage to the vehicle was moderate. Right and left side damage to the vehicle was minor. Both side impacts were to the rear portion behind the passenger compartment. Despite 4 separate impact events, the passenger compartment was intact with no significant intrusions. So our driver was a 66-year-old male, 5'9", 189 pounds, and he was protected by the available 3-point belt and the steering wheel airbag. His past medical history included the fact that he was a little elderly, below normal bone mineral density, and he has hypertension, depression, and acid reflux. He was in the hospital for 10 days. This is a summary of his injuries. He had a left L2 and 3 transverse process fractures, bilateral L4 transverse process fractures, all attributed to the steering wheel, airbag, and shoulder belt complex, an L4 burst fracture with displacement of fragments into the canal due to the seat pan, and multiple avulsion fractures of the right distal lateral tibia, lateral talus, and medial talus, as well as a right tarso-metatarsal fracture and dislocation due to contact with the brake pedal. While none of these injuries is life-threatening, with his past medical history, they will take a significant amount of time to heal and likely will impact his life for some time. On the opposite side of the car, in the right front passenger seat, was his son. Only the frontal airbags deployed during the crash. The side airbags did not deploy since the direct impact was outside of the seating area. So the right front passenger was a 31-year-old male, 5'10", 165 pounds, also protected by the 3-point belt and frontal airbags, and he did not stay in the hospital at all. He was treated and released. So he's 35 years younger than the driver, a little bit taller, a little bit lighter, using the same restraints. He had no injuries at all. So the take-home lesson for this crash is that both occupants went through the same crash. They had identical restraints, identical stresses. The 66-year-old spent 10 days in the hospital, and the 31-year-old was discharged from the emergency department. The only thing different were the occupant factors. If we can now turn to the pediatric population, I have a couple of take-home lessons for you. Children are essentially more fragile than adults. The younger they are, the more fragile they are. Airbags and kids don't mix, and restraint misuse is frequent and markedly increases the risk of injury to these kids. A couple of facts. There are nearly 61 million children under the age of 14. Children account for 3% of vehicle occupant fatalities and 8% of all occupants injured. MVCs are still the leading cause of death for children from age 3 to 14. When they are used, child restraints work. Child safety seats reduce the risk of fatal injury by 71% for infants and 54% for toddlers. Lap and shoulder belts reduce the risk of injury 50% for moderate to critical injury in passenger cars and 65% for moderate to critical injury in light trucks. When you approach a vehicle with a child occupant, there are a number of things you will see that will help determine how you triage a child. For instance, you may come upon an unrestrained child, a child seated in the front row, restraints improperly used or installed, or an improper type of restraint, such as a child who should be in a booster but is simply using the lap and shoulder belt. You might also look for significant adult injuries in the same vehicle and intrusion into the child occupant's space. Pediatric injury patterns can be dependent on multiple factors, such as age, restraint use, vehicle type, or type of crash. There's a greater risk of injury in side impacts, and this slide shows what the difference between frontal impacts and side impacts can do to a child body. Children try to make themselves comfortable in a belt that doesn't fit them, and they are too small for adult-sized belts. Sometimes they put the shoulder belt behind their backs. They will scoot forward to bend their knees at the edge of the seat so they're comfortable. They tend to slouch, sleep, lean over, all different kinds of things. Additionally, belts hit them in the wrong places. Frequently, the belts will go across their abdomens, and even when the belts are in the proper place, their bones are not as developed as adult bones to take the stress. This is a pediatric case. The case vehicle is a 1994 Buick LeSabre. The driver stopped her vehicle at the stop sign. She did not see a 1997 Honda Accord approaching. She proceeded across the intersection and struck the vehicle 2, in a frontal manner. The case vehicle then rolled over 4/4 turns before coming to rest on its wheels. This is the approach to the impact. Approximate impact site in the middle of the intersection. And this is the vehicle. The front of the vehicle was severely damaged, with structural shifting of the front end from right to left. Overall, this is a severe oblique frontal impact with a delta V of nearly 30 miles per hour. This is the seating area of our case occupant. She was right behind the driver. Note that there is vertical roof crush from the rollover, but the side window is still unbroken. While modest intrusion is evident, the seating area of this passenger is largely intact. The 3-point seatbelt had evidence of use, loading evidence on the webbing, but it was reported that the shoulder belt was placed behind her back. Other than evidence of occupant contact to the seatbelt webbing, the left door suggested left side contact with the door armrest hip blocker. So our occupant was an 11-year-old female, 4 feet 11 inches tall, 75 pounds. She was the left rear passenger with a lap belt only, and she had a past medical history of occasional headaches. It was reported that she was asleep in the back seat, slumped over to her left, lying against the door with the shoulder portion of the belt behind her back at the time of the crash. Summary of her injuries includes an infrarenal abdominal aorta pseudoaneurysm, bilateral L2 transverse process fractures, L3 and 4 posterior dislocation with a complete cauda equina transection, devascularization of descending colon at the splenic flexure, partial transection and disruption of proximal jejunum, and a partial stomach laceration, all attributed to the lap belt. Additionally, she had a left mid-abdominal abrasion due to contact with the door armrest. So this is a photo of her abdomen. You can see her surgery scar there in the center. You can also see witness marks from the lap belt. Notice how little depth there is in this occupant. She's very slight, and she has those spinal column and intestinal injuries. That lap belt just cut right across her body. Circles in this slide indicate her pseudoaneurysm just below the kidneys. This is another photo of her back and left flank. Again, she's got that incision for her spinal fusion and that lap belt right up over the iliac crest. Another photo from the right flank. And what you're seeing here are the images after her spinal fusion. So the outcome for this patient, she has bilateral lower extremity paraplegia. She did have to undergo spinal fusion with T11 through L5 instrumentation, and she was only in the hospital for 9 days before she went to a rehab facility. Here's another pediatric case. Again, our case vehicle is in red, driven by the case occupant's grandfather. They were traveling down a roadway when another vehicle pulled out in front of the case vehicle, and the case vehicle struck it in a full frontal configuration. This vehicle was a 2007 Ford Taurus, and it struck a 2006 Dodge Grand Caravan. This is the approach to the impact. Roughly the impact site. This overhead view of the front of the vehicle depicts severe vehicle damage. Both frame rails were engaged, which provided optimal energy dissipation for the occupants. Overall, this damage is rated as severe with a delta V of 38 miles per hour. This is the seating area of our case occupant. He was seated behind the driver. Again, the seating area. There's minimal evidence of contact to the heavily padded interior of the vehicle, and no evidence of contact with the rear door. This occupant was a 14-year-old male, 5 feet 8 inches tall, 140 pounds. He was the left rear passenger and was wearing the available 3-point belt. He had no past medical history. It was reported he was asleep in the back seat, with the exact position unknown, and he states that he remembers being slung forwards and then backwards. His injuries include a colon mesenteric injury, small bowel mesenteric injury, retroperitoneal hematoma, L1 and 2 spinous process fractures, a right L2 pedicle fracture, and L2 vertebral body fractures. This was all attributed to the lap belt. You can see in this photo of his face, he's got a left frontal scalp contusion. This goose egg, you're looking at a head CT here, this goose egg corresponds exactly to that external abrasion. Photos of his abdomen. Again, the abdominal surgery scar right down the center. Witness marks from the lap belt. And again, notice how little depth this occupant has as well. He is slight, and again, that lap belt just cut right into his body. This is an abdominal CT scan. You're looking at a slice of it. And what I want you to notice here is that the spinal column is really in the middle of his body. The lap belt goes above his iliac crest and crushes into his belly, pushing the contents into that column of bone that's really in the center. Here you can see the kidneys at the bottom of the scan, and just to the left in that yellow circle is free blood, indicating an injury to the mesentery. Got some bowel thickening. It's a little hazy, again indicating there's fluid in his abdomen. For this occupant, the outcome is very different from the first child I showed you. While those injuries are similar to the first child, they are not nearly as severe. He was a little bit bigger, and he got a little bit luckier. His length of stay was also 9 days. Again, when you are assessing an occupant, it's important to look for the following: evidence that a child is unrestrained in a vehicle, restraints that were improperly used or installed, an improper type of restraint, or perhaps the child is seated in the front row. You can also look for significant adult injuries in the same vehicle and intrusion into the child occupant's space. Depending on multiple factors, age, restraint use, vehicle type, and type of crash, you may be looking at different injury patterns for pediatric patients than you are for adult patients. There is a greater risk of injury in side impacts. Pediatric take-home messages again are: children are more fragile than adults. The younger they are, the more fragile they are. Airbags and kids don't mix well, and restraint misuse is frequent and markedly increases the risk of injury. At the other end of the age spectrum are the elderly. This demographic, which is generally considered to be people aged 65 and older, is increasing. Some occupant facts: in 2008, 13% of the total U.S. resident population were people aged 65 and older. Older drivers make up 15% of licensed drivers. They account for 14% of all vehicle occupant fatalities. In 2 vehicle crashes, the older person was in the struck vehicle 58% of the time. Pre-existing conditions are common, with a gradual but steady increase as people age. By the 4th decade, 17% of the population has pre-existing conditions. By the 6th decade, 40% do, and by the 8th decade, 69% do. These conditions may include things like hypertension, dementia, cardiovascular disease, diabetes, or cancer. In addition, aging is characterized by a progressive loss of functional reserve. This loss is distinct from the pathological loss of function seen with comorbidities such as hypertension, cardiac disease, or diabetes. Age-related decline is subject to large individual variations, and chest wall injuries such as rib fractures can markedly decrease respiratory function, causing elderly patients with limited respiratory reserve to rapidly deteriorate. Some elderly take-home lessons: adults become more fragile with advancing age. The older they are, the more fragile they are, and the less reserve they have. Older occupants are a growing segment of the population, and they have a higher crash involvement rate. And injury patterns change as occupants get older. These are some of the elderly injury patterns in motor vehicle crashes. Again, let me stress that there is a greater risk of injury in side impacts. Elderly trauma patients have more pre-existing medical conditions and tolerate treatment delays poorly. It's important to keep in mind that medical events may have precipitated the crash, and vice versa. The driver of our case vehicle here, a 2001 Chevrolet Trailblazer, in red, was attempting a left turn into a driveway. He misjudged the distance, and Vehicle 2, in blue, struck his vehicle in an offset frontal manner. This is the approach to the impact. And the impact site with that driveway just to the left of the slide. Approximately 50% of the front end of the vehicle was engaged. Overall damage was rated as moderate with a delta V of 10 miles per hour. The driver was using the three-point belt, but the impact was not of significant magnitude to deploy the frontal impact airbags. He was a 95-year-old male, 5 feet 6 inches tall, 165 pounds. Again, he was wearing the three-point belt only. He had a complicated past medical history with comorbidities including diabetes, ischemic cardiomyopathy, prostate and bladder cancers, hypertension, and hypercholesterolemia. He also had some previous ocular surgeries. Current medications he's taking include Flomax, Timolol, Zantac, Lovastatin, and Imdur. These are his injuries. He had left anterolateral number 3 and 4 and right lateral and posterolateral 5 through 7 rib fractures and a mid-body sternum fracture attributed to the shoulder belt, a left scaphoid fracture and left radial styloid process fracture attributed to the steering wheel. This chest CT, these circles indicate his right lateral rib fracture and a left posterior rib fracture. This is a side view of his chest, and the circle indicates where the sternum fracture is. What I want you to look at here is how close to the heart this fracture actually is. Combined with the rib fractures, this fracture is extremely dangerous for an elderly patient. Here's his left wrist, and these fractures are in close proximity to each other, the styloid fracture being just at the tip of the radius, and there's a tiny line in the scaphoid bone just to the left of that styloid fracture. Some severe bruising on his right foot. So the outcome for this driver, they put a C-collar in place for his pain and splinted his left arm. He was in the hospital for his acute phase of treatment for 5 days and was discharged to a subacute rehab facility. 2 weeks out, he was discharged from rehab to go home, and 10 weeks later, he was still in a short arm cast and has a home care attendant every day. Turning to the passenger, this was his wife seated in the right front passenger seat. Airbag did not deploy due to the low crash severity, and she was belted using a seat-integrated three-point system. She was a 93-year-old female, 5 feet 3 inches tall, 135 pounds. Comorbidities included hypertension, heart arrhythmia, multiple spine fractures from a prior crash, and COPD. She also had previous spine surgeries and a cholecystectomy. Current medications she was on include Timolol, Zantac, and Lovastatin. This is her constellation of injuries. She has a right hemothorax with bilateral pleural effusions, mid-sternal fracture, both attributed to the shoulder belt, and some scattered bruising on her upper and lower extremities. So again, we're looking at a chest CT, and you're seeing the right hemothorax, which is blood inside the lung cavity. And here's her fractured sternum. Some bruises on her upper extremities. What I want you to notice here is the quality of the skin. The elderly usually bleed more depending on comorbidities, and they have a papery skin that sometimes will tear very easily. So the outcome for this right front passenger, again, she has a C-collar in place for pain. 4 days out, she was discharged to a subacute facility, and 2 weeks out, she was discharged from rehab. In contrast to the pediatric patients we just looked at, these two elderly patients had relatively minor injuries and spent a great deal of time either in the hospital or in a rehab facility before going home. Again, the elderly take-home lessons include adults are more fragile with advancing age. The older they are, the more fragile they are, and the less reserve they have. Older occupants are a growing segment of the population, and they have a higher crash involvement rate. And injury patterns change as occupants get older. This is another look at the changing injury patterns for elderly. Clearly, trauma patients have more pre-existing medical conditions and tolerate treatment delays poorly. And it is important to keep in mind that medical events may have precipitated the crash, and vice versa. Let's turn to another special population, the obese. 35.7% of all U.S. adults are classified as obese. There is high morbidity associated with certain coexisting diseases, such as hypertension, type 2 diabetes, coronary heart disease, stroke, gallbladder disease, osteoarthritis, sleep apnea, and respiratory problems. In 2008, medical costs associated with obesity were estimated at $147 billion. For obese patients, more mass equals more kinetic energy. It takes time for the energy to dissipate with a lot of mass, and there's not a whole lot of space for the energy to be gone before a body hits the vehicle. They frequently have ill-fitting belts. The belts were meant to hold the body in place, but work best when braced against a bony pelvis. In a larger person, there's more material to get through before meeting the bones, and this introduces some slack in the belt and cannot protect a larger body. Additionally, people who weigh the same are not shaped the same. Women tend to carry weight in their hips and thighs, men carry it around their middles. So if you think about those different shapes, the belt will fit them differently. Obese people tend to wear seatbelts less than thinner people. It's uncomfortable, so a lot of the times they just don't put it on. Here are some injury patterns for obese patients, and what I want you to notice here is the extremities take the brunt of the energy in a frontal impact. Our case vehicle here, shown in red, was traveling on a 2-lane roadway when an oncoming driver lost control of his vehicle, and the vehicle drifted into the path of our case vehicle. Our case vehicle is a 2001 Ford Taurus, and it was struck by a 1996 Jeep Grand Cherokee. This is a long, straight road, and there was snow and blowing snow at the time of the crash. This is roughly the site of the impact. And here's our vehicle. This is a severe full frontal impact with some override damage. Maximum crush of 85 centimeters was at the left front bumper corner. Both right and left frame rails are engaged, resulting in optimal energy management and dissipation. The driver's seat pan and backrest were deformed during the loading event. There was 1 foot of rearward toe pan intrusion, plus 9 inches of rearward instrument panel intrusion. The driver was a 25-year-old male, 6 feet 2 inches tall, 460 pounds. He did have the 3-point belt on, and the steering wheel airbag went off. His past medical history is significant only for morbid obesity. His hospital stay was lengthy. He was in the hospital for his acute phase of treatment for 31 days, where he was discharged to a subacute rehab facility. 3.5 months post-crash, he's still at the rehab facility. He's not ambulating, and the surgeons have planned an ankle fusion. If this fusion fails, he's looking at a below-the-knee amputation. These are his injuries. He had some rib fractures on the right, left L1 and 2 transverse process fractures due to contact with the shoulder belt, right distal radius and ulnar styloid fractures, and some small bone fractures in his right hand, all due to contact with the instrument panel. And what I want you to pay attention to here are these severe lower extremity fractures starting with his pelvis. So he has left superior and inferior pubic rami fractures, a left intra-articular acetabular fracture, bilateral SI joint diastasis, left distal femur fracture, and left patella fracture and complex meniscus tear, and those last 2 were open fractures. And this was all due to contact with the knee bolster. He also has left distal fibular shaft and lateral malleolus fractures, right medial tibial plateau fracture, right distal fibula fracture, and right trimalleolar fracture due to contact with the toe pan. Chest CT, so he has some rib fractures, and if you will notice here, there is a lot of extra tissue around the outside of his rib cage. The lighter gray are muscles, and the darker gray is fat. Here's his pelvis CT, and what you're looking at here in the upper left is the SI joint widening. So he's got an open book pelvis fracture. It's as if someone grabbed his iliac wings and pulled backwards, creating the widening at the back. And on the right, he's got an acetabular fracture where his femoral head fits up in here. That is a weight-bearing area. This is his left knee x-ray. It's essentially shattered. This is serious implications for his walking and daily tasks of life. Additionally, they are open fractures, so he will have problems with wound healing. And his ankle, left fibular shaft fracture. So this patient has injuries from his pelvis all the way down to his ankle on the left side. At 460 pounds, this is significant. Turning to the right front passenger, this is the driver's wife. You can see in this picture that the right front seat cushion is heavily deformed during the loading event and sort of ramps downward. Although she was belted, her forward excursion was significant and resulted in contact deformation with the instrument panel, knee bolster, and glove compartment door. She is a 23-year-old female, 5 feet 8 inches tall, 376 pounds. Again, she had the 3-point belt on, and the dash-mounted airbag did deploy. Her past medical history is significant for juvenile rheumatoid arthritis and morbid obesity. Her length of stay was a little longer than her husband's. She was in the hospital for 63 days before she was transferred to a subacute rehab facility. She developed complications and was readmitted to the hospital, then went back to the rehab facility, and 4 months post-crash was discharged to her mother's home. She can ambulate, but with a walker. Injuries include an aortic pseudoaneurysm with intramural hematoma, left rib fractures, bilateral pleural effusions, all due to contact with the shoulder belt, right distal radial fracture and right radial nerve injury due to contact with the instrument panel, bilateral acetabular fractures, right femoral shaft fracture and left femoral shaft fracture due to contact with the glove box, bilateral inferior pubic rami fractures, right iliac wing fracture and left sacroiliac joint diastasis due to a combination of the lap belt holding her pelvis and forward motion into the glove box, and a right talus fracture due to contact with the toe pan. Here, what you're looking at is her chest CT, and the pseudoaneurysm is inside the yellow circle. The layers of the vessels will pull up and create a flap, and then the high-pressure blood will go back in behind that flap and continue to dissect along the vessel. This weakens the vessel, and it must be repaired. She also has that left anterior rib fracture. Looking at her pelvis CT, and remember that the pelvis is a ring, so you can't just break one side of it. What you see here in the 3D image of her pelvis is that incredible widening at the pubis, and then also at the back in the SI joint area. She has bilateral acetabular fractures. These are her femurs. You can see that they are broken here. Continuing down her right leg, she has a right talus break as well. These are all weight-bearing sections on her entire right leg, all the way from the pelvis down to the ankle. Again, for an obese patient, these injuries are lifelong and can be debilitating. To sum up, again, obese patients mean there is more mass, and more mass equals more energy. Frequently, the belts are ill-fitting. Seatbelts were designed for a 50th percentile male, someone who is 5 feet 10 inches tall and approximately 185 pounds. If a body is shaped much differently than that, the belts don't fit right and tend not to protect as well as they should. Also, the obese population tends to wear seatbelts less often than thinner people. Another look at the obese injury patterns and crashes. A reminder of our obesity population take-home lessons are that this segment of the population continues to grow. They have a greater chance of comorbid conditions, and their injury patterns are different. They have more and greater severity of lower extremity injuries, fewer abdominal and head injuries. To review this module, the purpose was to teach you how to recognize and use occupant factors to determine which patients may need special consideration, and to get an understanding of how injury patterns are tied to occupant factors. This module has a special emphasis on pediatric, elderly, and obese populations. Take-home lessons are: occupant body composition affects injuries. These same characteristics affect recovery and outcome, and it's the occupant, it's the occupant, it's the occupant. Thank you.